trying to advance the slides, and for whatever reason they're not advancing, so I apologize for that. Oh, there we go. Okay, so just again setting the stage that the Joint Commission is very interested in your rates of exclusive breast milk feeding. That is the PCO5 mandate, and that is now actually a mandate as of January 2014 for all hospitals with more than 1,100 deliveries, although that too may change in the future, and all delivery hospitals may be required to submit their data. So being part of CHAMPS will definitely help you do that. I know Emily's been out helping every one of the teams figure out mechanisms that will be ongoing so that you'll always know what your real exclusive breastfeeding rate is. And so I'm just going to skip over this next slide because PCO5 will be remaining, and Emily will talk more about that. But as of October in 2015, the PCO5A measure is going to be going away. So, so that's one less thing that you'll be collecting as part of CHAMPS. And we think this is going to be a lot easier for all of you, so we're excited about that. So now let's really focus on the guidelines and evaluation criteria that are used by Baby Friendly USA to figure out whether or not Step 6, which is really the step that is put in place to ensure exclusive breast milk feeding, to avoid unnecessary supplementation, and let's really take apart this Step 6 according to the guidelines and evaluation criteria. And in doing so, I'm going to present to you each of the elements underpinning this, as well as some suggested verbiage that you can include in your own infant feeding policies. So the overall goal of Step 6 is that newborns that are breastfed should be given no other food or drink other than breast milk unless it is medically indicated. And that to do that, as we talked about last time, we should understand the physiology of breastfeeding, what's normal in the baby, what's normal in the mother, and really push the envelope on what the true medical indications for supplementation might be. And then if a supplement is deemed necessary, this is really for each hospital to determine whether this is something that can be nurse-driven or physician or APN-driven, whether there needs to be an order or not, and we'll return to a little bit of discussion around that at the end of today's webinar. But first and foremost, I think we need to identify in your hospital every single policy or protocol that would in some way come into play when there's a consideration for supplementation. I'm going to highlight some of the real common policies that do come into play. So the first part of the Step 6 guidelines and evaluation criteria is that there should be a process in place for mothers who request breast milk substitutes. We hear this all the time when we travel, that there are certain populations that are always requesting to combination feed. We hear from the Latino community, Los Dos is a common phenomenon. But I think it's really important that every mother, every family be treated individually with the opportunity to address any concerns or any misconceptions, certainly, that the family may have, and not to come about this in somewhat of a stereotypical or prejudicial manner to just assume that combination feeding is going to be the norm. So Baby Friendly does this by exploring and addressing the mother's concerns, and to do that, all of the staff have to be really comfortable in engaging in a conversation with every mother and every family about the fact that she is choosing to breastfeed, which is terrific, and we want to support that, and that really in the hospital, the best way to support continued breastfeeding is to support exclusive breastfeeding, because even if later down the line moms want to introduce something in addition to her own milk, it's going to be impossible to continue her own breastfeeding. Not impossible, but it's much more challenging to continue breastfeeding if breastfeeding is supplemented early on. And I think that's the message that the staff has to really understand, and they have to be comfortable in educating moms about what's termed here as the negative consequences of feeding infants breast milk substitutes, but really what we call, certainly throughout the educational arena, whether it's prenatal education or in-hospital education, the risks of formula feeding. What are the risks of formula feeding in the breastfeeding baby? And then document this education. So the staff, once they engage in this conversation and identify mother-specific, really family-specific information, that information should be documented. And so if a mom requests supplementation, you can use text similar to this for your infant feeding policy that basically describes what I just talked about, so that if a mother should request supplementation, the mother is supported to exclusively breastfeed and educated about the risks of supplementation, et cetera, and that's all then documented in the chart. And so this is just some verbiage that you could include in your infant feeding policy that goes along with the practice. But what are you going to actually say? So what are the risks of supplementation? So for the mom, supplementation will definitely decrease her confidence in breastfeeding. There have been a number of studies looking at maternal self-efficacy and early supplementation. There's the presumption that the low volume of colostrum that's normally produced, that's part of normal physiology, is somehow insufficient because it's a low volume, and that supplementation therefore is necessary. And so this really undermines mom's confidence that the body's made to do what it's made to do, which is to produce sufficient quantities of milk and actually support the needs of the baby. In addition, there's physiologic reasons why it's important not to supplement for mom, because if the baby gets supplementation, the baby will be less likely to remove milk from the mother's breast, and milk left behind in the mother's breast there then leads to local autocrine control. There's hormones that are made locally in the milk-producing alveolus that actually cause downregulation in the rate of milk synthesis, and ultimately this is the breast mechanism to protect itself, and so if no milk is removed from the breast, then ultimately milk synthesis stops. And so one way to avoid this is to have frequent and effective emptying of the breast, and by doing that, milk synthesis continues in a very robust fashion, and mother's milk supply then increases in a robust fashion, and that way the mom's concerns really ultimately, once the second phase of lactogenesis begins, the mom's concerns about insufficient milk production go away, because in fact her milk production is much greater than if she were supplementing right from the beginning. And then there's epidemiologic evidence, really a ton of epidemiologic evidence, that any supplementation in the early newborn period, the first 2 days of life, leads to premature weaning. And so that's what I was alluding to earlier, that even if down the line mothers are saying that they want to do both ultimately, really the way to do both is to keep the breastfeeding going. Otherwise, ultimately, babies end up exclusively formula feeding. So it's important not to supplement particularly early on so that breastfeeding continues after discharge. The effects on the baby are really all the things that I talked about the last time. We know that any supplementation causes diseases in the baby, short and long term, and changes the normal microbiology and immunobiology of the very sensitive developing infant's gut. And so it's really just one drop, one bottle, one anything. So that's an important thing to always remember. Anytime you're thinking about supplementing, having that information kind of at the forefront of the staff's awareness. And then the effects on the dyad. So by giving babies supplementation, again, they're going to be less apt to want to latch on and maybe having an ineffective latch. And again, less latching and less suckling at the breast causes less of the stimulation of the nerves that go from the breast to the mother's brain, releasing prolactin and oxytocin, both hormones that are necessary for the continuation of breastfeeding. So then documenting this. This can be documented in a number of ways in both paper and electronic charts. You can have drop-down menus where you can click on the things that I've listed here, the need for the supplementation, what's the medical indication, is there an order for the supplementation, when the supplementation was given and when it's going to end and how much is given and what type of supplementation. Remember, not all supplementation means that it's non-human milk. The first type of supplementation really is to give expressed mother's own milk, followed by expressed donor milk, and followed then by a breast milk substitute such as formula. And then how that supplement's provided is really important, and we're going to come back to that. This is something that's very often forgotten, which is to give the supplement in a method other than a bottle and nipple. So in terms of those medical indications for supplementation, this is really where we kind of roll up our sleeves and dig down to the difficult conversations about weight loss, hypoglycemia, and hyperbilirubinemia. And I think these are the three kind of hot button issues when it comes to frequent, what we might deem as non-necessary or unnecessary supplementation, but are often used as, quote, medical indications for supplementation. So I think it's really taking each one of these conditions and looking at it in a way that increases the threshold for giving a supplement. So, so what kind of texts would you include? And again, we're going to go into this in more detail, but you might include things such as weight loss, although I'm going to try to guide you against doing that. But certainly some charts have weight loss as an indication for supplementation in the medical record, and I think that can be very problematic. Many protocols that I've seen also have the frequency of voiding and stooling, and again, I'm going to show you some data that will hopefully minimize language about voids and stools as being an indication for supplementation. What about the baby that just hasn't latched in a number of hours? And again, I've seen policies that say, well, if the baby hasn't latched in 6 hours or 8 hours, then supplementation is indicated. Again, I'll show you some evidence why that's not necessary. And then latch scores. And I think that this latch scores or something analogous might be probably the best piece of information to put in the medical records in terms of medical indication. So first, in terms of weight loss, so we did a study with the project director up at Boston Medical Center, which is, as you know, baby-friendly hospital, looking at what is the normal weight loss pattern of healthy full-term babies. And it was clear that babies lose weight, first of all, and yet being in a baby-friendly setting, none of the babies that we followed in the small cohort actually lost more than 10% of their weight. And I think that this speaks to the fact that, number one, it was a baby-friendly hospital. Number two, their cesarean section rate was very low, so there's probably very little overhydration using IV fluids in the mothers delivering. And that the mean weight loss in this cohort altogether, all feeding methods together, was around 5%. But then when you break it out and look at babies that are exclusively breast milk fed versus mainly breast milk fed, compared to those that are mainly formula fed or exclusively formula fed, there were clear differences in the weight loss, the maximum weight loss that we saw in the babies. And definitely the babies that are exclusively breast milk fed lose the most weight. I think we know that intuitively. But as we know, many of the hospital policies and many of the staff perceptions are drawn from a time when exclusive formula or even combination, mainly formula feeding, was the norm. So I think just getting to that comfort level with the fact that weight loss is normal, that in a baby-friendly setting even, you may see as an average of 6%, but that's with a range that may go as high as 10% and may have a lot of variables that are underpinning. The other thing that's important to recognize is that the weight loss nadir, meaning the time that the babies reach the maximum amount of weight loss, continues to happen for many babies. In this case, almost 40% of the babies continue to lose weight even after discharge home, which is usually 2 days after birth. And so in a population where the babies may be going back to their pediatric care provider and lose weight maybe the day after they go home compared to the day of discharge, that could be normal, and I think that's an important message for the pediatricians to know. So there was a very highly publicized national study that was published by Valerie Flowerman, who's from San Francisco, but in collaboration with Ian Paul and the group from Penn State recently, that tried to define what are, in fact, the normal weight loss patterns of babies that are exclusively breastfeeding, born first by vaginal birth and then separately babies born by cesarean section, again recognizing that C-section may lead to overhydration of the baby, which through diuresis may lead to excess weight loss after birth. And what I can tell you about this, number one, is that many of the babies that were enrolled in the study were not being cared for in baby-friendly settings, so that may actually mean that these estimates are greater than a baby that might be in a baby-friendly setting. So in some ways, it's a little bit more liberal in terms of looking at what might be the normal patterns. And a curve that might be derived from a baby-friendly setting might be a little more conservative, and you might think that there's more excess weight loss than what these curves would suggest. So in that way, it's kind of good because maybe there will be less overshooting in terms of medical, quote, medical indicated supplementation. But I would caution you about using these curves as a way to determine indication for supplementation, because every baby has a number of different reasons, a number of variables that might lead to weight loss or certainly lead to excessive weight loss. So you need to really get a history about the baby, about the latch, about the mother. Could there be a delay in lactogenesis in the mother? Could there be hormonal problems in the mom? I think it's really important not to just use these curves as a standalone method to try to determine whether a particular baby is normal or not normal, or is in need of supplementation or not. So this is just some guidance. As I said, I think it's very dangerous to use weight loss alone to indicate the wellness or not so wellness of a particular baby, and as a method to indicate whether or not supplementation could be used. You could both overshoot or undershoot depending on the situation. So the things to assess then are actually the breastfeeding itself using a scoring system. You can use the latch scores, as I alluded to earlier. Many of the electronic health records now have the latch score embedded into the EPIC record. My personal favorite actually is to use the mother-baby assessment scoring system that was developed by Chris Mulford. The reason I like that is that it was a scoring system that involves not only looking at the baby's latch and swallowing and really aspects of the baby, but really gets some verbal record of how the mother thinks the feeding went. It really gives us an indication of what the mom was feeling, what she experienced, which I think gives a lot more information about any one breastfeeding episode. You could do other things to try to estimate milk transfer, such as test weights, but again, I would use those only in specific clinical situations. Understand that somewhere between 6 and 7% is a mean weight loss, but actually that too might be an overestimate. There are some studies from places outside of the United States that actually have a mean weight loss that's much less than that. So maybe even in the U.S., our baby-friendly environment, is not even as supportive as outside the U.S., where babies lose very little bit of weight, or it may not even be anything to do with the breastfeeding support, but maybe the obstetrical care for mothers outside of the U.S. While we would define 10% weight loss as excessive, it's not really a good indicator to say, yes, definitely supplementation is necessary. And certainly babies that routinely lose 10% or more in your institution, if that's happening, I would really look at the obstetrical procedures such as IV fluid prior to delivery and C-section rate. So in terms of just feeding and output, again, alluding to that I's and O's, whether you can use voids and stools as a method of determining adequacy of feed. Certainly when babies were getting formula feeds and getting them in a bottle, babies were really overfeeding, getting way excess in amounts of normal physiologic feeds. Babies were voiding and stooling a lot. And so, again, protocols that may be written based on a time when babies were just getting a lot of volume may be erroneous compared to what should be in place and what's normal in terms of the exclusively breastfed baby that is feeding only half an ounce to an ounce total volume in the first day. Remember, the purpose of feeding in the whole first day of life is not for nutrition. It's really to establish the immune system for life. And so in this very nicely done study by Chen in 2011, they looked at 313 healthy newborns, and they actually conducted this study initially to look at hyperbilirubinemia as the outcome, but interesting, they also measured voids and stools. And they were divided into 3 feeding groups, and the feeding group represented by the exclusively formula feeding babies are represented here by the hash marks, and then the very dark, solid, well, almost solid, sort of partially dotted line, but very dark line is represented by the exclusively breastfeeding babies. And they looked at voiding and stooling in these babies. And as you can see, the exclusively formula-feeding babies had significantly more voids and stools, but really just for the first 3 days of life. And then starting on day 3 of life, you can see the exclusively breastfeeding babies' stooling patterns after the second phase of lactogenesis started really skyrocketed, and as many of us know, in the breastfeeding world, breastfed babies stool practically with every feed, and so the stooling frequency was much greater than the other 2 populations. And again, this is physiologic, but provides the rationale for why having voids and stools in the chart or in the policy as a threshold for supplementation is probably not a great idea, because you're going to be supplementing really unnecessarily, given that the threshold in many cases may be derived from these exclusively formula-fed babies, and they're going to be the only ones that are meeting the norm, so to speak. So infrequent void and stool are normal to begin with, and then catches up after day 3 of life. What about the baby that just hasn't latched? And again, I've seen this written into policies very often, that if the baby hasn't fed in X number of hours, then babies should be supplemented. Well, if you're doing step 4 and babies are suckling in the delivery room or in the OR, in the recovery room, that may be sufficient really for the next 8 or 12 hours Often babies have this period of awakeness and alertness right after delivery. They'll have a more effective suckling pattern right after delivery. And then, delivery is tough, so they may sleep for a long time after that, and then follow that long period of latency by frequent suckling, maybe even every 30 minutes for the latter part of the first 24 hours of life. So it's really not so much a volume issue in terms of the baby latching. The main issue with latching, for the baby's perspective, it's not that the baby needs to get a supplement because the baby hasn't latched. The main issue with latching, the problem with not latching at all and not suckling at all, is that the suckling that the baby's doing, because of the gastrocolic reflex, because every time the baby suckles, you get the stimulation in the gut, and that stimulates stooling, as I showed you, that stooling, even a few stools, may be protective in terms of the bilirubin levels from rising. In addition, the suckling for the mother is, again, what stimulates lactogenesis. So if the baby's not latching and suckling very frequently, then the mom should begin hand expression, and then the baby can be fed her expressed milk. What about latch scores? So again, as I mentioned, latch scores are often embedded into the electronic health record as a way to assess breastfeeding. Interestingly, the Baby Friendly Hospital Initiative and the 10 Steps don't really have breastfeeding assessments as a criteria for the guidelines, but really the AAP, the American Academy of Pediatrics, and others do believe that doing breastfeeding assessments is a good idea, and certainly the field concerned with jaundice or hyperbilirubinemia is very concerned with being able to do breastfeeding assessments because it's really poor breastfeeding that can lead to problems. So using the latch score in this particular study, they were able to demonstrate that in the healthy full-term babies, the latch score of greater than 7 really indicates that things are going well. In the babies that are preterm, even the late preterm babies, we know they're the great masqueraders. A latch score of 7 doesn't necessarily, even a latch score of 9 isn't 100% consistent with good breast milk intake. So I think for the healthy full-term babies, the latch score is a pretty good measure. If it's less than 7, then that is probably an indication that breastfeeding is not going well. Again, babies should feed mother's own expressed milk, but that may be an indication where, we can't just let them kind of hang out there at the breast, that some intervention is probably warranted. And then the late preterms, I think, that's when we have to start using some additional measures such as test weights and other indicators for the late preterms that may look like they're suckling pretty well, but in fact they're having difficulty with milk transfer. So what about jaundice? I kind of alluded to this issue of jaundice as being problematic, and certainly in many settings just having a bilirubin over a certain threshold is written into policy as an indication for supplementation. I would say that that's not a good idea. We know that all jaundice is not bad. In fact, bilirubin is an antioxidant, so bilirubin is actually physiologic. It should be there. It's protective. It's a good thing as long as it's not too high. Everybody's so worried about bilirubin levels that rise really to very high levels. We don't know what that level is. We think it's somewhere in the 20s because when it rises to that level, it can enter into the brain and lead to some brain damage and a problem called kernicterus. So that's what everyone fears. So for babies that are having trouble establishing breastfeeding, breastfeeding has unfortunately been sort of implicated as the innocent bystander for hyperbilirubinemia. We used to call this starvation jaundice, and I'm not even sure that's such a great name because that, again, implies that it's a volume issue. It's really lack of suckling jaundice, and I think it's important that we distinguish this early excess bilirubin from not suckling versus the healthy, great feeders that have breast milk jaundice, that occurs usually after a week of life, and that is really a different problem and not really an indication for supplementation. So how do babies get jaundice? I mean, what's the mechanism underpinning the relationship between breastfeeding and jaundice? Jaundice or bilirubin comes from the breakdown products of the heme molecule that's in the red blood cells. Babies are born with a ton of red blood cells. That's a good thing. But all those red blood cells can be very fragile, and some break, and there's other reasons why there may be breakdown of heme in an excess way early on. And so there's no problem in synthesizing the bilirubin from all this breakdown, and that then goes into the bloodstream, or it actually begins in the bloodstream and then is presented to the liver. And in the liver, there are two rate-limiting steps. One is uptake into the liver, and the second is a conjugation that occurs in order to get rid of the bilirubin. And after conjugation, comes out of the liver and goes into the intestine. And really that's why that gastrocolic reflux is so important, to get babies suckling so that babies poop out their bilirubin. And that's one mechanism of getting rid of it. If it doesn't get pooped out, it actually gets unconjugated again and then enters back into the circulation by this process called enterohepatic circulation. So the longer the bilirubin hangs around in the gut, the more opportunity it has to re-enter into the bloodstream. So getting babies to stool by frequent feeding, certainly by day 3, is one really important mechanism. By day 3, they're stooling frequently, but even day 1 and 2, they should have several stools, and the suckling will help move the bilirubin along. We used to use this scoring system called the Kramer scale to determine how jaundice babies were. In the old days, we used to hold the babies up to the window and see if the bilirubin extended beyond the head and chest. The bilirubin tends to sort of increase in a cumulative fashion, in a cephalocaudal fashion. So the first place to get jaundice is the head and neck, followed by the chest. And then if the trunk and lower extremities are jaundice, then that really means the baby's bilirubin level is very high. So we used to use this mechanism to determine just how jaundice babies were. In a fairly recent study by Jeffrey Maisels, he actually wanted to see how good this Kramer scale was. He called it the jaundice zone score. And there was actually really good correlation between the jaundice zone score and the risk of significant hyperbilirubinemia. There was an R value of 0.72, which is really pretty high. However, because of the wide range of the serum bilirubin levels, this was the score matched against the serum bilirubin levels, particularly at the low levels of the JZC, or the jaundice zone score. The recommendation is that unless the score is really high, where you're going to probably get the serum bilirubin anyway, it's probably not a good idea to rely on this visual inspection by itself. So the bottom line is, these days, just about every hospital is measuring in some objective way the serum bilirubin level, either through a transcutaneous or through serum bilirubin levels. And once you get that bilirubin level, it's then really important to ask two questions. And this whole field gets really confusing because the word risk is used so many times. But the two main questions are, number one, is the baby at risk for hyperbilirubinemia, the kind that might lead to kernicterus? And you answer that question by using the risk zone, which I'm going to show you. And then the second question is, does the baby need to get phototherapy to treat the hyperbilirubinemia? And to do that, we have to then add on to other risk factors. Again, that word risk. So I've just given you like an example of a baby who's 48 hours of age with a bilirubin of 13. There's this really cool bilitool.org that's online that many hospitals use. And in this case, this baby would fall using the nomogram that I'll show you in the high intermediate zone. So what that tells you is not that that's an indication for the baby to get a supplement, no. Not that that's an indication for the baby to get phototherapy, no. It tells you when to check the next bilirubin level. It tells you how at risk the situation is and whether to check the next bilirubin. In order to make the decision of whether or not to use phototherapy, you have to then look at risk factors. So again, just going back, we determine the risk zone. Again, you look at the 48 hours postnatal age and go up on that line. I don't know if you can see my cursor, but just pull up on that line to 13. You can see that this particular baby falls in the high intermediate risk zone. The good thing to know is that this nomogram that was developed by Vinny Butani has really good sensitivity and specificity. This is what we call a ROC curve, or receiver operating curve, which tells us just how predictive this risk zone based on this nomogram is in terms of identifying the proper babies to work up, which is a good thing. We're not, it tells us not just in a very sensitive way, but also doesn't put too many false negatives into the mix so that we're not over-treating. And that's a big issue with hyperbilirubinemia. So when we use that nomogram, there's a nice grid that was published by Butani, and all of this is actually being rehashed right now by the Hyperbiliary Task Force from the AAP in the hopes that new guidelines are going to come out and be actually a little bit more breastfeeding friendly. So if the baby has low intermediate bilirubin level, then depending on those clinical risk factors, then we might determine some intervention. But like I said, this baby in a high intermediate zone would definitely get another bilirubin checked and be followed closely, but not supplemented. Breast milk would still be provided, and in some cases this baby may get phototherapy if there's other risk factors or if the rate of rise is very high. So this is the grid of those clinical risk factors that I alluded to, and this is where breastfeeding really comes into play, and I think this is something that is going to take a little bit more evidence to try to tease out. So the guideline that was most recently published described the breastfeeding risk factor as exclusive breast milk feeding if poor feeding. But the poor feeding was qualified by weight loss, unfortunately, and I just told you that weight loss isn't a good indicator by itself, and I don't think it is, and it probably is more to do with the suckling than the actual volume going in or the weight that's being lost. And so that's probably one thing that will be changed, hopefully, in the upcoming guidelines, is to really further define what poor breastfeeding is to determine if the baby has a major risk criteria, which would then guide an intervention such as phototherapy. Not necessarily supplementation. In all these cases, breastfeeding or breast milk feeding is still supported. So this is the nomogram that's used for phototherapy, which again is probably safest to do in a hospital setting because you can recheck the bilirubins in an ongoing way. Breastfeeding can still continue, and I'm going to show you a picture of how that can continue in a little bit. But the determination for which baby gets phototherapy really goes back to those risk factors. One huge risk factor is the late preterm babies, or the babies that are not fully termed because of the enzyme that's in the liver that doesn't conjugate that bilirubin because it's just not produced in sufficient amounts in a baby that's not term. In addition, babies that have genetic problems such as G6PD, where there's a lot of hemolysis, those babies would be at more risk as well. So how do we prevent this jaundice in the breastfeeding baby? And really the answer to that is early and frequent suckling because that's going to improve passage of meconium and also will facilitate lactogenesis too through prolactin. And this was demonstrated a long time ago by Yamauchi's studies showing that babies that breastfed fewer than 9 times per 24 hours actually in a stepwise fashion were more at risk to getting jaundice. And so Jeffrey Maisel has attempted to publish, again, similar to Valerie Farren's weight loss curves, what the normal bilirubin curves are for the exclusively breastfeeding baby, and just like with the weight loss curves. And I think this is good information to have, and I just put the star on there for that baby that we described, the 48-hour-old baby that was had a bilirubin of 13. It's good information to have. You can say, oh, good, he's on the green line. That's going to come back down to being normal range if we just are patient enough. But you need to gather more clinical information. I think that using a curve alone is not a good way to determine treatment. And I just wanted to include this as another potential solution for practitioners that do want to use a breast milk substitute. If you're going to supplement for a bilirubin reason, the best way to supplement is to use a hydrolysate formula. This is a study using Nutramigen. The nice thing about using Nutramigen, illustrated here by the red bar, is that it brings the bilirubin level down much more rapidly and at a much lower level so that you can actually do away with the Nutramigen soon after initiating it. It's also much more analogous to a medicine, and so parents might see it as a medicine, which means that they'll use it only for a temporary reason and then go back to breastfeeding. And this is the photo that I alluded to earlier about how to do phototherapy and continue breastfeeding. This is a study done by King of Susan, Indiana, showing that they can actually do phototherapy in the hospital with a setup that provides the lights while skin-to-skin, babies can still breastfeed ad libitum, and moms can wear protective eye gear so that she can safely be in the same environment with the baby. So hypoglycemia, another huge hot-button issue. The most important thing is to test only the babies that are at risk. Many places are still testing every baby, and that's just unnecessary. You're going to cause hypoglycemia if you continue to do heel sticks on every baby, as opposed to really just treat babies as they should as normal babies. But definitely babies that are born to mothers with diabetes or those that are late preterm, babies that are small for gestational age or LGA. LGA is so common these days as well. And then babies that are symptomatic should be placed on a protocol to test for hypoglycemia. So I've just put in here a couple of caveats. It's so important. I can't tell you how many times I find that there's such a rush to get the glucose level, even in a completely asymptomatic baby, that we forget everything about skin-to-skin. The AAP protocol supports the fact that you can have even babies at risk, asymptomatic babies at risk, be skin-to-skin, which is really going to maintain their blood sugar, and support the first breastfeed. And you have 2 hours to complete the first glucose measure. So you can support skin-to-skin care. Babies can, on their own, latch to the breast, suckle, actually get that first feed. If they don't have a great feed, mothers can hand express and be fed express breast milk. And you have all that time, and then check the baby who's asymptomatic. And this is the AAP Committee on Fetus and Newborns protocol for hypoglycemia. Just be aware of and notice where the thresholds are in babies that are within 4 hours of birth. Their thresholds are much lower, so babies can be monitored with glucoses as low as 25, so 25 to 40 is a range for refeeding and continuing to monitor. It's not an indication for supplementation. Certainly if it goes below that, we usually treat those babies in the NICU. And then that threshold goes up a little bit, but not as high as 55 or 60, which I've seen in some NICUs. I mean, if you're going to set your threshold at 55 or 60, all babies are basically going to be called hypoglycemic, and they're really not. They're really just illustrating normal blood sugar levels. So the third part of this Step 6 policy should be administering supplementation feeds if they are deemed necessary by alternative means. So identify what's good for your hospital in terms of the options that you have, if it's a cup or a syringe, um, and then putting in that medical order for supplementation. Um, so again, this could be a physician's order, it could be by policy or protocol, it could be just nursing-led and not necessarily by protocol, so clinically individualized, which I think is probably been better. You can have a supplementation policy that indicates certain situations to be watchful about, but I think having things like weight loss nomograms or bilirubin nomograms as an indication for supplementation just may cause more trouble than it's worth. And then in terms of what is supplemented with the preference for mother's own milk, followed by donor milk, followed by breast milk substitute, and then volume. Again, I've seen so many supplementation policies where their supplementation volumes are excessive, even on the first day of life, as much as 30 cc's per feed. And for hypoglycemia, and that's just unnecessary. Again, physiologically, babies can feed 5 to 10 cc's per feed. Again, those alternative feeding devices, the staff need to be educated using skills fairs, and then the family should be educated as well, and can actually do this. I've seen support persons in the room spoon feeding babies, mothers express milk when latch is difficult, and that just is a great illustration of a terrific baby-friendly environment, knowing that that support person was educated to be able to do that. So why no bottles? Why are we using these alternative methods? What's the evidence? The strongest evidence really is in the premature babies, but I'm going to show you some studies that have been done. This whole notion that there's nipple confusion in babies that are developing breastfeeding skills really dates back to the origins of the Baby-Friendly Hospital Initiative, with this theory that artificial teats could interfere with the baby's normal oral suckling patterns. When they did a study in Canada, just seeing which staff members would be more supportive of this concept, so just looking at attitudes, and with the simple question of, do you think giving bottle feeds leads to nipple confusion? Interestingly, the level 2 nurses, the nurses that worked in the NICU setting, actually felt less likely. They were less likely to think that bottle feeds would lead to nipple confusion. But the postpartum or mother-infant unit type well-baby nurses and pediatricians actually fairly frequently, although still not close to 100%, felt that it would lead to nipple confusion. So I think that we still have a huge challenge in terms of just attitudes. In a randomized controlled trial that was conducted by Cindy Howard, they were able to demonstrate that the highest risk population, the C-section babies, seem to have the most problem with getting bottle feeds, that cup feeding in this case, significantly prolonged exclusive breast milk feeding, but the well-baby population didn't seem to have any difference. It was really just a supplementation or not that led to the rates of breastfeeding after discharge. So this is the more recent study that gives us an indication, in fact, that it's the late preterm baby that are probably most susceptible to this concept of nipple confusion. And bottle feeding versus cup feeding was different in just about every measure related to any breastfeeding, duration, and exclusive breastfeeding, both at discharge and duration. So I think that the more vulnerable babies certainly have the most risk in terms of different methods of feeding, and that's why it's so important to just standardize that if supplements are given, that they're given in alternative means. Again, it's important to practice this and make sure that the staff has good attitudes about using this. And lastly, and I'm not going to spend a lot of time on this because I know Dr. Muirwood's doing a whole webinar on this, the procurement for breast milk substitutes. And this is really where the code of marketing comes into place, but this is part of step 6, that breast milk substitutes and all the feeding devices have to be procured using fair market value and that nothing's given for free, and that you're not giving samples, and that parents aren't getting marketing materials or educational brochures that are marketing anything that would be covered by the code. So I think I got through everything. So really writing a supplementation policy, as I think I've demonstrated here, is pretty complicated. It's not necessarily just one policy. It's really important at the get-go to get all the players around the table that have a role. So your neonatologists, your pediatricians, your OBs, as well as nursing staff from all the various units, and talk about what the indications are, talk about the evidence that I've shown you today, and just make sure that everybody's on the same page so that when you then write your policy, then you can feel confident that everybody feels good about the policy that you're upholding.